Minute. Okay, I think we'll get started. So, welcome everybody. My name is Rob Madden. I'm a geriatric psychiatrist in Toronto, Canada, where it's sunny today and 9 a.m. Eastern Time. Welcome. I'm the chair of the Journal Club, the International Psychogeriatric Association Journal Club, and also some of our other educational products and services. Um, Welcome, and I'll introduce our speaker in a moment and our topic. Um, so why don't we just go to the next slide, Christian? So just FYI, what the International Psychogeriatric Association is, if you haven't heard of us, the IPA has been around for a long time, for 40 years, really a leader in the field of psychogeriatrics. Our membership uh, includes people from all sorts of different disciplines, so people who are interested and passionate about late life mental health disorders. And we welcome everybody to come to our website, take a look around, see what we offer in terms of recorded materials and the benefits of membership. We do a lot of advocacy and we liaise a lot with other like-minded associations. Next slide, please. Yeah, just in terms of membership, we've got the good old QR code in the corner at the top there, just to let you know that our members have access to all of the recorded archived materials of our webinars, our debates, our journal clubs, and other things. So our online education portal is available to you as a member. We also have an early career network for people who are just starting off. Um, our journal, international journal, and there's lots of other opportunities in the IPA. If anybody's interested in learning more, please come to our website or reach out to any of us. Next slide, please. Just another reminder that we've got our next International IPA Congress in Japan in September 2025. There's a QR code. It takes place in Kanazawa, Japan. So we look forward to seeing you there if you'd like to attend. It's going to be beautiful. Next slide, please. Just some quick housekeeping. If you have a question, we're probably going to do the question and answer after the presentation. We're going to do the presentation for probably about 30 minutes, and then we're going to open up for discussion. That's the nature of our journal club. And just keep your audio muted during the presentation, and that will be helpful. Then you could unmute. If And during the question and answer, you could put up your virtual hand and I'll call on you. And if you're able to turn on your video and your audio, then great. If you can only do audio, that's fine. If you can't, you want to put your question in the chat, we could do that as well. So right now we're only 33 people, so it's an intimate group, although 150 registered. Okay, and also just to let you know that this will be recorded today and will be posted on our IPA learning portal. Thank you, Christian. Next slide, please. All right, never mind the picture of me. I want to introduce our speaker today, Dr. Maria Kryza-Lacombe, who has graciously offered to present this journal club today. And uh, the way I try and find articles is that I look through our journal, the IPA journal, International Psychogeriatrics, and try and find the most interesting articles I could find. That came across this one about anxiety, depression, cognitive disorders, and some imaging and amyloid. So this is really interesting. It's very interesting to me. Great topic, and we could talk a bit about that later, about sort of clinical implications and things of that sort. So Dr. Kryza-Lacombe is an assistant adjunct professor, Department of Psychiatry and Behavioral Sciences at UC San Francisco, and completed her PhD at the San Diego State University, UC San Diego, joint doctoral program in clinical psychology with an emphasis on neuropsychology. And her research focuses on the intersection of mental and cognitive health and has been informed by perspectives from neuroscience, neuropsychology, and mental health with a strong focus on clinical translation. Dr. Kryza-Lacombe examines the neural and neuropsychological mechanisms underlying emotional and cognitive dysfunction and resilience in older adults, and how these mechanisms can be leveraged to inform cognitive and behavioral prevention and intervention efforts to optimize well-being and vitality during aging. So I hope you've all had a chance to look at the article, and if you don't have the article, it is available to you. It was made accessible to you. And that was probably in the invitation. Dr. Kryza-Lacombe, I'll hand it over to you. We're going to walk through the article, and then there'll be the questions and answers. So thanks, over to you.
Fantastic. Thank you very much. Let me go ahead and share my slide set. Okay. All right, thank you very much for this introduction. Hi, everyone. It's really great to be here and an honor. And I'm excited to present on this paper my co-authors and I published last year in International Psychogeriatrics. And as Dr. Madden mentioned, this paper focuses on anxiety, comorbidity, and late life depression. Here are some learning objectives for today. So my hope is that today's presentation and discussion will generate an appreciation for the relationship between anxiety and anxiety comorbidity in late life depression and neurobiological factors, as well as how anxiety relates to cognition and functional ability in this population. I will also note some potential clinical implications for managing comorbid anxiety and depression in older adults. Just a quick note before I move on, I do have a bit of a head cold, so forgive me if I have to go off camera for a moment to cough, but hopefully this won't happen too often. So we know that late life depression frequently co-occurs with neurodegenerative diseases of aging. And we also know that late life depression is highly heterogeneous, both clinically as well as neurobiologically. But what we still know very little about is how heterogeneity within late life depression relates to features associated with neurodegeneration. Nearly half of individuals with late life depression also meet criteria for an anxiety disorder. And this comorbidity is clinically meaningful because it's associated with worse treatment outcomes as well as increased risk of depression recurrence. And so overall, anxiety is a key source of heterogeneity within late life depression and could be linked to distinct underlying mechanisms. Neuroimaging and neuropathological studies have shown that anxiety in older adults is associated with brain changes tied to emotion regulation and neurodegeneration. And what was found most consistently is reduced volume in the orbitofrontal cortex and the insula. Those are regions that are central to emotion processing and behavioral flexibility. Some other areas that are implicated include the amygdala, the anterior cingulate cortex, and the temporal lobes. These findings are less consistent. And anxiety has also been linked to hallmark features of Alzheimer's disease as well as cerebrovascular disease, such as amyloid plaques and white matter hyperintensities. But these findings are largely from general aging samples, and the relevance to individuals with late life depression is still pretty untested. Cognition and independent daily functioning are certainly crucial to aging well, and anxiety appears to interfere with both of these. Older adults with anxiety consistently perform worse on cognitive tests and show greater risk of impairment, even after accounting for depression symptoms. When anxiety and depression co-occur, cognitive outcomes tend to be worse than with either condition alone. And functionally, higher anxiety in the general older adult population has been tied to poorer daily functioning. But again, in the context of late life depression, these links remain unclear. And studies that do exist, they typically fail to control for depression symptoms in their analyses, making it difficult to isolate the independent effects of anxiety. So I hope the rationale for this study has already emerged from the previous slides, but in summary, prior work linking anxiety to brain structure or pathology has mostly looked at cognitively normal older adults or those at risk for dementia, and not specifically those with late life depression. And there's evidence that anxiety is related to both neurobiology and cognition, and our goal was to see how anxiety operates specifically within late life depression. So, and if anxiety reflects a distinct pattern of brain structure or pathology, or if it's more tightly linked to cognitive decline, this could help us disentangle the complexity of late life depression. So, our aim was to evaluate how anxiety severity within late life depression is associated with corticolimbic volumes, amyloid beta deposition, white matter lesion burden, cognitive performance, and daily functioning, all while controlling for depression severity to isolate anxiety-specific effects. So a little bit about the sample and the design. This was a cross-sectional study and included 121 older adults between 65 and 91. All had major depressive disorder. And diagnosis of MDD was established through clinical consensus using the 17-item Hamilton Depression Rating Scale, as well as a structured clinical interview for the DSM-4. Excuse me. And participants were included if they were experiencing a current depressive episode lasting at least 6 weeks and did not have any psychotic features. Exclusion criteria, individuals with other Axis 1 psychiatric conditions were excluded except for some anxiety-related disorders like generalized anxiety disorder. Other exclusion criteria included major neurological disorders that could affect cognition or brain structure, such as TBI, Parkinson's disease, or epilepsy. We also excluded individuals with dementia, and we operationally defined this as a score of below 25 on the mini mental state exam or a clinical dementia rating above 1. Here is a list of the key measures we used in a study. Anxiety was measured using the GAD-7, which is a self-rated symptom severity scale, and individuals indicate how anxious they have been over the past 2 weeks. Depression was measured via the geriatric depression scale, and this is what was used as a covariate in our models. And so here are the variables of interest. So corticolimbic volumes were extracted via free surfer from an MRI scan, which was acquired via 3 Tesla MRI. We also had an MRI flare, and that's how we measured white matter lesion burden, which was quantified via total white matter hyperintensities. We also measured amyloid beta via floor beta peer PET, and we used a cortical SUVR composite compared to the cerebellum, or relative to the cerebellum. For cognition, we use the ADAS-Cog. The ADAS-Cog is an assessment that has 13 different subtests that measure things like memory, language, praxis, attention, and they're combined into a single score where here in this case, higher scores indicate greater impairment. And we measured functional ability using the Clinical Dementia Rating Scale. So this is a clinician-administered, semi-structured interview, and we use the sum of boxes for this measure. So, and the sum of boxes score includes daily functioning, such as how well the individual navigates community affairs, how they navigate life at home, their hobbies, and personal care. And here again, higher scores indicate greater impairment. Excuse me. A slide with our sample characteristics. We had a sample that was 68% female. As you can see here, the sample was predominantly highly educated as well as predominantly white. This certainly limits our ability to generalize our findings, and we do hope that future work can address generalization to the broader, more diverse population. In terms of anxiety prevalence in the sample, we had a good amount of variability. What you can see here is that about a quarter of the individuals in our sample had a concurrent anxiety disorder. Excuse me. And in terms of self-rated anxiety, I wanted to mention, so a quarter had any concurrent anxiety disorder, and the generalized anxiety disorder was was predominant with 20%. Then in terms of self-rated anxiety, about half of the individual endorsed moderate or severe anxiety in the sample. Okay. So our primary analyses were done via linear regression models that predicted our variables of interest. So cortical limbic volumes, amyloid beta, white matter hyperintensities, cognition, and functional ability. And for cortical limbic volumes, we focused our analyses on the orbitofrontal cortex and insula because those are the region that were most consistently associated with anxiety in an older adult population. But we also examined a few other regions, like the amygdala, anterior cingulate cortex, and the temporal cortex. Our main predictor in these analyses was anxiety, and anxiety was measured via severity, so the continuous anxiety variable. And we had some covariates, including age, gender, and as I mentioned multiple times already, we controlled for depression severity in these analyses. We had some additional covariates depending on the analysis. So for example, for the cortical limbic volumes, we controlled for ICV or intracranial volume to make sure that we account for different head sizes. And for the amyloid beta analyses, we covaried for APOE status, and with cognition and functional ability, we also covaried for education. All right, and on to the results. So these are the results for the cortical limbic volumes. We did not find an association between anxiety and insula volume, but we did have a significant association between anxiety severity and orbitofrontal cortex volume. And what you see here, the scatter plot is a partial regression plot. Sorry, it's just an association. So you see the association that we found between orbitofrontal cortex volume and anxiety severity. So smaller orbitofrontal cortex volume was associated with greater anxiety symptom severity. As I mentioned, we also examined a few other regions, including the anterior cingulate cortex, the temporal cortex, and the amygdala, but we did not find any association in our sample between those regions and anxiety severity. Excuse me. For neuropathology, neither amyloid burden nor white matter hyperintensities were significantly associated with anxiety symptoms in the sample of late life depression patients. But we did find some associations between cognition and anxiety. Specifically, higher anxiety was associated with worse cognition in the sample, controlling for depression severity, controlling for education and age. We did not have a significant finding for functional ability, but as you can see, this was a trend, and we may not have had so there may be a small but meaningful relationship that we were not able to capture with our sample. So after these primary analyses, to evaluate the relative associations of the factors that we found to be associated with anxiety, so in our case, orbitofrontal cortex volume and cognition, we ran a global regression analysis. And again, here we used anxiety symptom severity as the outcome. And predictors in these model included the factors that emerge as significant in the primary analyses, as I mentioned, as well as the demographic characteristics that we thought could confound the analysis. So age, gender, education level, and concurrent depression. And just an FYI, the volumes that were added to the model here were adjusted for intracranial volume, again, to control for the fact that different individuals have different head sizes. So when these are the results for the global model, when we entered both orbitofrontal cortex volume and cognition into this model, only cognition remained a significant predictor, as you can see here in this table, which suggests that this may be the strongest link to anxiety, which is cognition. And what you see here on the right is a partial regression plot of the association between anxiety severity and cognitive functioning, again, controlling for age, gender, education, concurrent depression severity, and orbitofrontal cortex volume. And as a reminder, cognitive functioning is measured such that higher scores indicate greater impairment. So what we see here is that anxiety symptom severity, again, is associated with greater cognitive impairment. So altogether, our study yielded several important findings. First, higher anxiety severity was associated with poor global cognitive functioning, which is consistent with earlier research in community-dwelling older adults, especially those with comorbid anxiety and depression, or co-occurring anxiety and depression, I should say. And this reinforces the potential cognitive vulnerability in anxious individuals with late life depression. We also found that anxiety was linked to smaller orbitofrontal cortex volume, which also echoes prior findings across the late life depression and general anxiety disorder older adult population literature. And while certainly this does not establish causality, it raises the possibility that orbitofrontal atrophy contributes to emotion regulation difficulties in this population. Interestingly, we did not find that the insula was significantly associated with anxiety in our sample once depression was accounted for, which suggests that the insula may be more closely linked to depressive symptoms. Importantly, we did not find any association between anxiety and markers of neurodegenerative pathology like amyloid beta and white matter hyperintensity. And this contrasts with findings in general aging samples, which implies that the depression context may modulate these relationships. Functionally, as I mentioned, anxiety was not associated with impairment in daily functioning, but there was a trend there. So it's possible that our sample had generally preserved daily functioning. We did exclude for dementia, so we may not have had enough variability there to fully explore this association. Altogether, these findings emphasize that anxiety in late life depression is linked to more to brain structure and cognitive health than to classic markers of neurodegeneration like amyloid beta and white matter hyperintensities. And finally, in the global model, only cognitive performance remains significantly associated with anxiety, which suggests that cognitive dysfunction is a key feature linked to anxiety in late life depression, perhaps even more so than structural brain changes like orbitofrontal cortex volume. That said, I do think that the orbitofrontal cortex finding still warrants further research, especially with longitudinal and functional approaches. There are several takeaways relevant to clinical practice. So first, the study suggests that anxiety and late life depression is important. So screening for anxiety in older adults with depression is important, as higher anxiety severity may signal vulnerability to cognitive dysfunction. Patients with comorbid depression and anxiety may benefit from interventions that target both anxiety as well as cognitive health. And so, in treating anxiety in addition to depression may improve cognitive outcomes, and vice versa. Addressing cognitive dysfunction, late life depression may improve anxiety. Excuse me. Um, and our finding that orbitofrontal cortex volume is associated with anxiety suggests that this region could be a potential neurobiological treatment target. Although orbitofrontal cortex volume was not independently predictive in the global models, the link to anxiety still suggests that it may serve as a structural marker of risk. As with any study, there are important limitations that I want to highlight. This is a cross-sectional design, which means it can determine causality. So whether anxiety leads to cognitive dysfunction or vice versa, or whether a third factor is driving both of those. Additionally, the sample I already mentioned this, may have limited the ability to detect smaller but meaningful associations. And because we had this restricted range of functional impairment in the sample, because we excluded for individuals with dementia. And because we excluded for individuals with dementia, certainly our findings may not generalize beyond this outpatient population without dementia. Looking ahead, one more thing that I wanted to mention for limitations, and I think I forgot to list it, is that our anxiety measure was a self-rating over the past 2 weeks, which is not ideal. Perhaps something more of a trait-like measure would have been more ideal. So certainly something that future studies may want to incorporate. Looking ahead, longitudinal designs, of course, very important. These would allow us to track whether anxiety predicts cognitive decline or atrophy, or whether cognitive changes precede the development of anxiety in late life depression. And future work may also want to incorporate functional neuroimaging and consider additional neural markers such as subcortical amyloid. So we are now restricted to cortical amyloid because we did not have subcortical variables to work with. So using these additional markers would allow us to paint a more complete picture. And certainly larger and more diverse samples are needed to confirm these findings and extend them to broader populations. I would like to acknowledge my research mentor, Dr. Scott Mackin, who is the PI of the ADNI Depression Project. The sample is a ADNI depression sample. So ADNI is the Alzheimer's Disease Neuroimaging Initiative, and Dr. Mackin runs the small depression sister study of it. And I would also like to acknowledge the Dolby Family Fund and Avid Radiopharmaceuticals for their support. And of course, I want to give a big shout out to my co-authors who are incredibly supportive in the development of this project. And with this, I thank you very much for your attention. Here's my contact information should you want to connect. I'm happy to connect. And I will hand the mic back over to Dr. Madden for a discussion.
All right. Thank you so much, Dr. Kryza-Lacombe. So you can, yeah, so that's great. Thank you.
Mhm.
So we've got time for discussion, and please feel free to put questions or comments in the chat, or you could raise your virtual hand, and then I'll be able to see your hand come up. Um, if neither of those appeal to you, you could unmute and just ask your question. But we've got lots of time, and yeah, let's see if anybody has any questions or comments.
I'm Dr. Nisa, contractor. I'm speaking to you from Queensland in Australia.
Oh, fantastic.
I just tried to send you a message, but it didn't go. So the one of the things that we see in these patients is that we learned before that sometimes severe anxiety can be a prodrome of dementia,
Yeah.
especially Alzheimer's disease.
Yeah.
And I was just wondering whether you looked at the hippocampal size or any sort of changes in that area, which would help us to sort of explain to the patients, to alert them about the risk of dementia or major neurocognitive deficit, and to encourage them to engage in CBT, because
Yeah.
treatment wise also nothing works for them, and they have severe insomnia also at the same time. So that's another challenge, and they don't sleep at night, and they get up with anxiety and panic in the middle of the night, and
Yeah.
we fear that we don't want to make them dependent on benzodiazepines.
Of course.
And so we are lost. We are at a loss as to how to treat them. I currently have two elderly women in the ward with exactly this, the picture of this depression, anxiety together. They are
Yeah.
not sleeping. They are very severely agitated, and
Yeah.
they are worried about their future. And
Yeah. No, I think, yeah, thank you for bringing that up. The hippocampus has not been consistently associated with anxiety in the literature. We did not formally evaluate it in this study. Certainly something we can do. So if you are really curious, I can run the analysis and let you know, no problem. Um, but yeah, I mean, it's tricky because like once factors like sleep are in the picture, it certainly confounds the problem. And we did not look at sleep in this study. And and I think that would be a really interesting thing to see to what extent sleeping difficulties may exacerbate the anxiety these individuals are experiencing. So yeah, it's challenging because I think what you're bringing up here is just this heterogeneity of how late life depression presents and how anxiety presents, and these studies, when we have all these and so many individuals, they only can allow us to consider one aspect of this heterogeneity and not multiple. So it's so hard to tease apart, and I'm excited that hopefully studies will become larger and larger so we can look at all these moderating factors that you're mentioning. Thank you so much for your comment.
Thank you. That's a great question. Any other questions or comments? So I think I'll have a go, and but please, as you're thinking, feel free to put it in the chat, or you can raise your hand. So my question is, I mean, I have a bunch of questions. The I mean, look, it's hard to do research, and I really I find this really interesting, and I agree with our first question that people with late life anxiety or anxious depression, depression with anxious distress, it can be very, very challenging to treat. Is there anything about whether or not these are first episode um, patients with like kind of first episode or new onset depression and anxiety, compared to those who've had it recurrently in their lives?
Yeah.
We always worry about these folks ending up with a neurodegenerative disorder. There's all that research
Yeah.
about, late life depression. Was it early onset? Was it late onset? And that relationship with depression. So I
Yeah.
wonder if there's any, if that changes anything. I don't think that was in terms of the data, there was nothing really about whether or not these were recurrent episodes or first onset. Does that make any difference here?
I wouldn't be surprised if it does. I think that this is something that we discuss a lot in our group, late onset versus earlier lifetime, history of depression in this population. It's really difficult to disentangle because it's hard to isolate samples that are only late onset or first episode and to make them large enough to have any meaningful analyses. So in our sample, I think they are predominantly earlier life onset. So this is not first episode that they have had at least, I think most of them have at least two or more episodes. So I agree, and I think it's so important to look at this. And I think that if we perhaps isolated individuals who have their first depressive episodes late in life versus others, we may see different links. So this is really this is a sample where we just put everything together and this is what we get. But I wouldn't be surprised if this is a important moderating factor that we need to explore.
And there's a suggestion that exposure to cortisol, high cortisol levels might damage the hippocampus over time.
Oh,
But
interesting.
there's also some thought that the later onset might be more in keeping with a neurodegenerative disorder. Yeah, it's very complicated. It's a
Yes,
whole
yeah.
other talk, I think, right?
Yeah, that's right.
A whole other talk. Okay, any other questions or thoughts? Again, it doesn't necessarily be about the paper. It could be about the paper, but also just around people's experiences clinically and the challenges and how this fits into things, or anything else about the paper that you want to bring up or have a question about. Okay, so we have Dr. Paul Loughlin. Go ahead, sir.
What psychotropic
We
medication?
cannot hear you for some reason. We can't hear you, Paul.
Oh, sorry.
Oh, yeah, now I can hear you a
Yeah.
little. Maybe get really close to the mic.
Okay. I may have missed it, but were they on? Did you look at what psychotropic medication the patients were taking?
Yeah, so we did not exclude individuals that were taking antidepressants. We just required that individuals are on a stable dose for the past 30 days. So I think most of them were antidepressant. I don't have the numbers off the top of my head, but it was a mix. We did not we didn't want to restrict the sample to just individuals who are not taking medications, which certainly is a confounder here in our study.
I guess one other question would be, would it be worth looking at tau pathology?
Yeah, absolutely. Absolutely. We do not have tau for this sample. We just we are currently looking forward to collecting tau data in our samples. So absolutely. I think this is exactly where our team is going.
Thank you.
Hmm.
That was a good question. Thank you. All right, so the medications, people could be on medications, but I guess there wasn't necessarily an accounting of how many or which kinds, right? In terms of,
Correct. We do have that data. We do have the data. If anybody is interested, I'd be happy to pull that and describe the sample more fully. I did not include
yeah,
the.
right.
Mhm.
Because you can imagine if someone's on anticholinergic like antidepressants, like the
Yeah,
old tricyclics or maybe paroxetine or
absolutely.
any benzodiazepines or
Yeah,
dead drugs,
so true.
might so that would be that would come as a covariate, I guess, or you would have to choose your sample
It
differently.
is, yeah, it's really tough. Again, like, with these different types of, factors of heterogeneity in the sample, like it's really difficult to control for it. Um, like because like we can create a binary variable to control for it, medication or not, but then it doesn't account, for the mechanism of the specific medication. So it's just really tough with a sample as small as this. I mean, it's a fairly large sample, but still to conduct these type of moderation analysis
Sure,
is
sure.
really challenging. Yeah.
And that question also just reminds me that with depression, with anxious symptoms as well, it could be harder to treat. and sometimes more treatment refractory, needing longer trials, higher doses, people often end up on medications that are not necessarily the best for cognition. You try serotonin reuptake inhibitors or SNRIs, and sometimes those fail. And then what do you do next? And people become desperate and can't sleep. And so there you go. You end up on Z drugs or benzodiazepines, or sometimes I don't know with you guys, but sometimes I end up getting into nortriptyline as the good old backup plan for people who are treatment refractory. And sometimes it works. So you have someone who has a cognitive issues and are very anxious, you put them on a tricyclic. Makes no sense. It goes against all geriatric psychopharmacology rules. But as the person gets better. So anyway, let's keep going. Any other questions or comments from anybody here? You can put in the chat or raise your hand or just unmic. Unmute, rather.
While we were waiting for another question, I did want to just make a comment here to what you just said, Dr. Madden. I'm a neuropsychologist, so I'm not a prescriber. But as a neuropsychologist, cognition is something that I look at, and I know that when patients present with anxiety, a lot of times they have difficulties with cognition as well. And this is, the main finding in our study. And, I do wonder to what extent supporting them with compensatory strategies, supporting them with, figuring out how to manage their daily functioning in the context of these changes that they're noticing could be supportive to these patients in addition to any medication regimen that you are providing.
Yeah, at our hospital, we have something called goal management training, which is really called like frontal executive dysfunction.
Oh, awesome. Yeah.
I think that might be even problem-solving therapy used for depression. It's really helping your frontal lobe. I mean, it's what it's helping with. So we have just a couple of things in the chat to bring your attention to just to cross-promote. We have the first link there is for our evaluation for this session. Please, my job depends on it. Please fill out the evaluation. It'll take you just 2 seconds. So the link is right there. There's also our link for the IPA Congress in Kanazawa, Japan in September 2025. Beautiful Kanazawa. It should be great. We also have the International Geriatric Mental Health Education Network, GEMH, which has a WhatsApp group and great talks on a monthly basis, coming out of Baycrest in Toronto, University of Toronto, some of my colleagues. And we've got a great talk on anticholinergic medications. So there we go. Perfect connection. And please consider signing up for that. It's terrific. We also have another IPA webinar on personality disorders. And it's something that's just not talked about all that much. We do a lot of dementia talks and lecanemab and aducanumab and all sorts of things, but we're going to talk about personality disorders. And for anybody in the trenches, I mean, this would be very fascinating. So we've got some great speakers, again, international speakers. Okay, we have a question here from Sherry's iPhone. Did you break down specific cognitive problems, i.e. the type? So I guess frontal executive versus memory versus attention. That's a good question because you might even say, well, of course, people with anxiety have poor attention. So yeah, global functioning will be affected by poor attention.
That's right. Yeah. Thank you so much for this question. And I was expecting that question, and I'm happy to report that we did publish a separate paper in the Journal of the International Neuropsychological Society last year as well, which looks at cognition more granularly in the late life depression population in relation to anxiety. And so what we found is that anxiety in late life depression is associated with visuospatial and a language functioning. So higher anxiety within late life depression is associated with visuospatial and language functioning, so confrontation naming specifically. We had some smaller effects for things like attention and processing speed. So if you want to learn more about that, check out that paper.
Thanks very much. That was a good question. Any other thoughts, comments? Yeah, go ahead.
Can I ask one question?
Yeah, go ahead.
About,
You're a little choppy, but
what are your thoughts about using MOCA B for cognition? I wanted to ask about the use of MOCA B for assessing cognition in the elderly. Just a screen,
Mocha
as a screen.
as a screener. Okay, Mocha B. I am not familiar. Is that a new version of the Mocha?
This looks like this something. I don't know whether you can see it.
that the Mocha Blind, is that what you're talking
Oh, the
about?
Mocha Blind? Oh, no.
Yeah,
Good visual stimuli. Yeah,
it
no,
says it is called MOCA.
I am not familiar with the Mocha B. I am familiar with the Mocha, but not this one. I'll have to check it out. Mhm.
Because I use this usually, and it's oh, I don't know, it went off. Sorry.
Mocha Basic. Okay, interesting.
I think that B probably stands for
B
basic,
is
I
for
think.
basic.
Yeah. Hmm.
And it has got those pictures also below. They have these scrambled pictures that you have to recognize in 1 minute.
Oh, interesting. Uh-huh.
Yeah, and the rest of it is like is the usual thing, about there's an executive function on the top
Uh-huh.
to draw the numbers with the dots.
Mm-hmm.
And so you go to trail, number one goes
Yeah.
to one dot, number two, then two goes to two
Yeah.
dots, and then from there to three, then three dots. So the executive function is tested with that one.
Very cool. Yeah,
And
thanks for
I was
sharing
just
that.
wondering that, yeah, it gives you a score out of 30. So we know we don't use much of MMSC now. We are mostly
Mhm.
using MOCA these days. In most of the people in Australia, clinicians and psychiatrists in
Okay.
Australia, we use MOCA or MOCA B.
Very good.
So
I'll
we have left the
familiarize
MMSC
myself.
behind.
Is it also out of 30 points?
Sorry?
Is it also out of 30 points?
No, 30.
13.
The MOCA B is
13.
up to 30, yes.
Got it.
So 23 is the cutoff point, just like in MMSC, we used to
Okay.
take 23.
Got it.
So we take the same cutoff point as 23.
All right.
Well, thank you. Now we're all going to look up Mocha B.
That's right, exactly.
I mean, there's so many different things you can use to assess cognition. I often use the Roland Universal, the RUDAS.
Mm,
Rudas, yes,
You know,
yes.
when I was in training, we had the MMSE, and then we did
Yeah.
clocks, and we did
Yeah.
alternating
Yes.
sequences and go, no-go tests and all sorts of different things.
Yeah.
So,
Yes, you're right. I always do the clock drawing. Once I finish the MOCA B, it doesn't have the clock drawing, but I
Mhm.
always do the clock drawing at the
Yeah,
same time because it picks up so much information.
it
We pick up
does.
so much information from that clock drawing also.
and we just heard that visual spatial might be affected.
That's right.
So,
Mhm.
ways to assess that.
Yeah, and I put the link to the paper I mentioned in the chat if anybody's
Thank
interested.
you. I
Thank
was hoping you might, but I don't want to push you.
you. It's fine.
Okay. Any other questions from anybody else? Okay.
So before you end, did you come across anybody who was suicidal because of their severe anxiety? Because sometimes we know that sometimes severe anxiety, many people can become suicidal, and the rate of suicide could be higher than in anxiety people who are anxious than only when they are depressed. So the anxiety drives them into that severe anxiety, panic, and in that state they commit suicide sometimes.
Yeah, yeah. Yes, such an important factor as well. Thank you for bringing up all these things that could affect these folks. So yeah, we measured we had a measure of suicidal ideation. I don't have handy how many of these individuals were experiencing, but again, like if you're very interested, I would be happy to pull those data for you. But we did not look at this yet. I think would be really cool thing to look at next.
Thank you. Okay, and we'll go back to Dr. Paul Watland.
Two things. Did you record the substance use, alcohol intake?
Yes. So we excluded individuals who had an active substance use disorder. We did not exclude for history. I do not have the numbers handy in terms of how many individuals have history, but none of these have active substance uses or alcohol use disorder.
And just one other thing. Could you look at maybe doing a prospective study with the mood tracking and anxiety tracking up? Is that maybe something?
Yeah, absolutely. Are you talking about momentary ecological ecological momentary assessment? I think that would be really cool to do. Yeah, it's very complex. Logistically, of course, we do not have this planned yet, but what we do have is we have longitudinal data on these folks, and we have funding for the past few years. We have been collecting 3-year and 5-year time points for the sample. So, and we do have depression, anxiety longitudinal on these folks. So we definitely look forward to exploring that data set more longitudinally.
Thank you.
Great, thank you.
Yeah.
So I'll just ask Christian that we have some closing slides. Maybe we'll just go through those real quick. Thank you. Okay, so just to remind us about upcoming events. So we've got the IGMH, geriatric mental health rounds, and anticholinergic medications. So please consider signing up. And there's a registration link in the chat next. And we have treatment of personality disorders. Again, it's a IPA webinar. So we look forward to seeing it. It's going to be awesome. So please come and check that out. And the next one, Kanazawa. So there we go, is the QR code. So I want to thank you again. I want to thank Dr. Kryza-Lacombe for agreeing to do this. Thank you so much, Maria. It was lovely to get to know you, and I hope you feel better. You have that.
Thank you.
But this is good luck in your research. This is amazing, and I love the partnership between, family medicine, general practitioners, neuropsychology, social work, nursing, physicians, all the disciplines who are interested in improving the lives of older adults. If you're at all interested, guys, please take a look at the IPA website for other offerings. And thank you so much for coming today. And thank you, Dr. Kryza-Lacombe. Much
Thank you so
appreciated.
much for having me. I appreciate it.
Thank you very much. Thank you.
Take care,
Bye,
everyone.
everybody. Bye-bye.